Hi, everybody. Thank you for joining us and welcome. We are delighted to have you, our audience, joining us from 6 continents today. So we truly have a worldwide audience who is very interested in this important topic. In recognition of Rare Disease Day, NF2 BioSolutions is happy to bring you this webinar. We're going to be learning about understanding NF2-related schwannomatosis with our speakers, Professor Gareth Evans and Dr. Scott Plotkin. I'm Mary Sell, board member at NF2 BioSolutions, and I'm the parent of an NF2 fighter. And I'm joining you today from Iowa, which is in the center of the United States. We have a couple of general housekeeping tips for you. This webinar is being recorded, and the recording will be posted on the NF2 BioSolutions website. You can submit your questions during the webinar in the Q&A panel, and we also have quite a few questions that were submitted with your registration, so thank you for sending those. We will get to the questions in the second half of the webinar. Captions are available for this webinar. On the Zoom Rooms controller, you can tap or click on the captions icon, and you may need to tap on the more icon to see that. Just a quick update about what NF2 BioSolutions has been up to recently. We are currently in a campaign to raise $300,000 so we can manufacture our AAV9 plasmid. So we started this campaign in November, and thanks to many generous donators, including some of you in the audience, we've raised 90% of that goal in about 3 months. We're at $270,000 raised, and we do need to raise $300,000 to begin production of our plasmid. So we are hoping to raise this by tomorrow, Rare Disease Day. If you would like to donate, we would appreciate your support. You can scan this code or go to the NF2 BioSolutions website to see ways to donate. And we're going to manufacture this DNA blueprint called the plasmid, which is a piece of DNA that acts as the instruction sheet to tell the gene therapy AAV9 what DNA to deliver into the cells. Once we've been able to manufacture this plasmid, we'll be able to go to submit an investigational new drug application to the FDA and then start a clinical trial. So we are getting close. We're really excited about that. Please help us raise the remaining money. And I am going to introduce our speakers next. We have Professor Gareth Evans with us. Professor Evans is an internationally recognized expert in cancer genetics with particular expertise in neurofibromatosis and inherited cancer syndromes. He has played a leading role in developing clinical genetic services in the UK and has contributed extensively to national guidelines and training programs in hereditary cancer care. Professor Evans has published over 1,000 peer-reviewed research papers and led major national research initiatives in both breast cancer risk prediction and NF2. His research focuses on neurofibromatosis types 1 and 2, inherited tumor predisposition, and imaging in hereditary cancer syndromes. We are also very grateful to have Dr. Scott Plotkin with us today. Dr. Plotkin is a professor of neurology at Harvard Medical School and the director of the Neurofibromatosis Clinic at Massachusetts General Hospital. Dr. Plotkin is also the chief of neuro-oncology at Mass General. He provides clinical care for patients with NF1, NF2, schwannomatosis, and other disorders. He has led numerous clinical trials for neurofibromatosis. Dr. Plotkin is currently the co-chair of research endpoints in neurofibromatosis and schwannomatosis, also known as RAINS, which is an NIH-sponsored group focused on the development of trials and endpoint development for neurofibromatosis. He is a key opinion leader in neurofibromatosis clinical trials and research, and he has published extensively on his work. We are so grateful to have these world-renowned experts with us today. So thank you for your time, and you guys can take it away. I'll stop sharing, and I think Dr. Evans will put up his screen.
If I can, I've sent a request to share. Okay, yeah, that's good. If I can find the right slide.
Okay, there we can see it.
Okay, so I'm going to really give some bare bones of what NF is and the genetics. The really important stuff comes with Scott after. Hopefully, it will be of interest to many of you. That we mixed up NF1 and NF2 for so many years, given that they are so different. The difference is obviously NF2 is much rarer. We now know that, in fact, probably more than 70% are de novo, and this is in more detail. Very different in terms of skin involvement. The low-grade malignancy is almost entirely just ependymoma, which usually are very indolent tumors and predominantly centrally located in terms of the tumors in the central nervous system, and obviously two different genes. And NF2 is characterized by the development of schwannomas on both eighth cranial nerves, causing deafness and imbalance. The great majority of these occur on the vestibular nerve, so the nerve for balance. Very occasionally they occur on the cochlear nerve. MRI is the gold standard in terms of picking them up. CT used to miss tumors over 1 centimeter in diameter in the past. The general population has over a 1 in 1,000 chance of getting a sporadic vestibular schwannoma. In fact, with increasing use of MRI, it's probably near a 1 in 600. And if you scanned every 80-year-old, you'd probably find about 1 in 100 would have evidence of a vestibular schwannoma. And what's interesting about it in NF2 is that these tumors are what we call multifocal, almost from the start in NF2. So I don't know if you can see this, but there are little dots all the way along both the inferior here and the superior vestibular nerve. So on each side, there are about 7 different individual tumors at the very start of this process. And this is why the tumors are harder to operate on. They're multilobulated because they're multiple tumors in many, many cases of NF2. And it's also why radiation doesn't work as well, because you're not treating a single tumor where you can get a high hit rate in the middle of it. So the majority of symptoms that people present with are related to vestibular schwannomas. So you can see here, hearing loss is the predominant one, and you get tinnitus sometimes as the first feature. But meningiomas that are the presenting feature. Those are the tumors on the lining of the brain and sometimes on the spinal cord. And they can present with headaches, visual loss, seizures, other features, paresthesia, and pain tend to be related to spinal tumors. And again, these and weakness and wasting, and these account for about 15% of presentations. And then quite a few people present with what's called mononeuropathy, where a single nerve stops working properly, often in childhood, and this can cause a facial weakness, any tumor is there, or loss of loss of muscle function in the legs or even in the hand. So a foot drop is often a feature. And ocular presentation is common also. But it's very different in children. So in children, only 21% present with vestibular schwannoma symptoms. The predominance of presentation is many, many different things. As I said, mononeuropathy is common, weakness and wasting, visual loss, skin tumors, etc., etc. So vestibular schwannomas usually do not become evident in terms of symptoms until late childhood. And that's why we don't tend to start until around 10 to 12 years of age, unless it's a very severe family. And this is the age of onset of symptoms in the 600 plus NF2 patients I've seen. And you can see here that about 25% present in childhood, and about 50% present by about 22 years of age. But there is a long tail here, and this is the mosaics who present later in life. Because the genetic fault isn't in all the cells, it hasn't been inherited from an affected parent, they present a much milder and later onset. So this is the sort of timeline of NF2. It was first described by a Scottish surgeon called in 1822, and the real problem with the conflation with NF1 was caused by a very famous neurosurgeon called Harvey Cushing, who said that you developed bilateral eighth nerve tumors in von Recklinghausen disease, and such was his weight in the profession that no one dared challenge this for many, many, many years. And in fact, it wasn't really until the 1980s that this started to get properly separated out. And this is why NF2 has had the misnomer of being called neurofibromatosis when you don't get neurofibromas in NF2. And then we first described NF2 in 1995, a lot on genotype phenotype, the gene being cloned in 1993. We launched our highly specialized service commissioned in NF2. So in England, all NF2 is funded through 4 specialist centers. And then obviously one of the biggest breakthroughs was Scott developing the use of bevacizumab, and we were the first country to approve bevacizumab, and we've treated over 200 patients in the UK with NF2. So obviously these are the old diagnostic criteria, which are sort of developed to allow a diagnosis with a unilateral vestibular schwannoma and other features, and multiple meningiomas and other features. And actually that is quite a useful diagnostic tool. And Scott and I were involved in the development of the new criteria, which are not, which use major and minor. I'm not going to go into huge detail as we haven't got time, but some of it has been updated to include things like retinal hamartoma, epiretinal membrane at a young age, and also the genetic testing, so that you can't get a diagnosis unless you have more than just genetic testing. This is just showing you this sort of the changes to those criteria. So in terms of how common is NF2, there have been a number of studies over the years, and in the UK, we currently, and I'll show you the UK data, have about 1 in 55 to 1 in 60,000 people diagnosed at any one time. But the actual birth incidence, so those that are actually born with the condition, and the mosaics will still have the condition at birth, in terms of the cells that carry the genetic fault, it's about 1 in 28 to 30,000. So we've assessed the prevalence in the UK, and this shows you this. This is the north of England, which we manage from Manchester, which is about population of about 18.5 million. You can see here that 3 of the centers have really very similar rates, and we think that The London one, which is perhaps a little harder to manage, I think they're not necessarily getting all the cases through because there's so many different neurosurgical units. So I think this is a very stable estimate of around 1 in 55, 1 in 57,000 with the condition. But look over here and see what a small proportion of these cases are actually inherited from an affected parent. Only somewhere between 30%. So the great majority are de novo, and a high proportion of those are mosaic. And when you look at this, you can see the proven mosaics here. So many proven mosaics. And in terms of the proportion, the estimate from proven mosaics is about a third, but we now know that it's probably nearer 50% if you're able to get tumors from all the individuals concerned. And this is a little bit about the different types of genetic change. A nonsense variant is where basically a change in the gene, a mutation, stops a protein at that point in the reading frame of the gene. And the same thing happens with these out of frame deletions and insertions. It stops the formation, and you get either a truncated protein or no protein at all from that copy. The milder sorts seem to be the missense variants, which only change one building block in the protein, which is one amino acid. And there is also, I'm going to very briefly touch on the exon 1 frame shift changes, which we now know are associated with very mild disease. And you can see the p-values here that for these being a much lower proportion are de novo. So because it's milder, you tend to get it passed down from generation to generation with these milder types of variant. And in terms of the prevalence of the other types of schwannomatosis, very much rarer. You can see here that it's 1 in 500,000 for LZTR1 related and 1 in 1,000,000 for SMART-B1 related, although that may be a little bit of an underestimate because we haven't necessarily been able to test everyone with that. Now, I know this is mainly a patient group that's listening to this, so with me on this, but we do look at, people will be aware that there is life limitation in NF2, but the good news is that that's really changing, that the survival and quality of life with survival is improving dramatically in recent years. This shows you the really bad mutations, the truncating mutations, as I said, the nonsense and frame shift variants give the poorest life expectancy. But then we've got this exon 1 thing, with exon 1 variants causing this much milder disease, and exon 14 to 15 also causing much milder disease, almost close to the normal population. But what's really interesting is the era effect. So these show the eras from 80 to 89, and this is 90 to 99, and 2000 to 2009, and this is the current era. And we've shown a general improvement in survival over that time. And we updated it in 2022, and you can see most of these deaths are in old age now, not at young ages, although there are still, unfortunately. And most of these are now not due directly to the NF2, although in the younger ones, obviously, they can be. And this is just a list of those. And this is just showing you the survival is so much better now. So NF2-related premature deaths are really quite uncommon. We, within 10 years, see well under 5%, which is our target, die within 10 years of diagnosis. So this is just the list of genetic changes, and I've talked about the different types here. What's interesting is this all reverses when we look at multi-generational families. And you can see here that splicing mutations go to the top, whereas nonsense mutations are at the top of the overall families. This is again showing you this genotype-phenotype correlation. And in the NF2 situation where it is inherited, we are able to identify 97% of the genetic changes, although we do need to use some additional techniques. But when we look at de novo cases, so the first in the family to be affected, we get a hit rate of under 50%. And this is due to mosaicism. So the genetic change isn't in all the cells. So what happens is the genetic change occurs after the egg and sperm come together. So it's in a patchy formation around the body, may even only affect the neural crest. And you can see here just how we show this in this patchy way. And if it's not in blood, then we can't detect it. And that's why we need to go and look at tumors. And for instance, we can calculate the likelihood of passing NF2 on even before you have a gene test, because if you're presenting with bilateral vestibular schwannomas, it's about a 50% chance that it's going to be mosaic. If you're presenting asymmetrically, where it's a unilateral plus other things, you're much, much more likely to be mosaic, showing this sort of uneven distribution around the body. And in this situation, if you have bilateral vestibulars before 20, it's very unlikely to be mosaic, and that's why the transmission rate is close to 50-50. But if you present over the age of 40 with a unilateral tumor and other features, then the transmission rate is only 9%. And that drops further once you do genetic analysis of blood. So we currently have 330 proven mosaics. And this just shows you how the pickup rate drops off the older you get with a diagnosis. So in purple here, you can see in the young people, we find it in almost everyone, but in those over 54, over 70%, we do not find the underlying genetic fault. And even in those, quite a high proportion where we do find it, we find it mosaic from tumors. So we do have this genotype-phenotype correlation, as I've said. You can see with truncating variants, the age of onset is half of that of those with the missense variants, where there's just a change in one amino acid. But this also shows you the hierarchy of this exon 1. We've now worked out that the early exon 1 frame shifts, instead of you not having a protein at all, there's a reinitiation starting codon, and that means you get an almost full-size protein in those rare families. We do have 30 patients with this, and they have the latest age of onset, even milder than the missense variants, and a much lower death rates, almost normal life expectancy. And we can even show a difference between the early exon 1 changes and the later ones, which actually are very similar to the general population. You can see here the later ones have of age of onset of 20 compared to 45 in the early truncators. And this is work by Miriam showing that we actually see the product. And finally, just a few slides showing the effect on meningiomas. You can see the earlier in the gene, the worse it is. Exon 14 and 15 showing you this much lower chance of developing a meningioma if you have a truncating variant. And again here, this is asymptomatic at diagnosis because you're diagnosing it from affected family members. A high proportion of missense and early truncators we diagnose pre-symptomatically by testing for the genetic fault. So overall, just rub in the new name, NF2-related schwannomatosis. We should not be using neurofibromatosis. We did have a go at changing the gene symbol, but they didn't like that. It was so well used, so we've had to keep the gene symbol, but I think that's okay. Just saying over 70% of cases are de novo, but that is predominantly those older onset cases. There is a very strong genotype-phenotype correlation, which I've shown you, and it is the highest mosaic condition among all tumor suppressor genes. So such a high proportion, over 50% of de novo cases are mosaic. And as I said, survival is improving dramatically, partly due to bevacizumab and the other drugs that are coming on stream that Scott is going to talk about, but also through better management. And in the UK, we do have very good management now with the 4 centres nationally. And that I'd just like to acknowledge all my colleagues in the service in Manchester. Thank you. And that was 20 minutes. So I'll stop sharing.
Great. Should I share? Yeah, let me. Okay. Did it work? Let's see. Not yet, huh? It looks like it's working. Is that correct?
Yes.
And is this the correct or the incorrect setting?
That's good. It's full screen. Yeah.
That's full screen. Okay, well, thank you very much for the invitation today to present. It's always a treat to present with my colleague, Professor Evans. And I have to tell you, I always learn something. So I'm hoping we can get all this down in a book one day. Really important observations there and ones that I use in my daily practice. So I was asked to speak today about a clinical trials update, and I woke up this morning and didn't like my presentation, so started from scratch. So if you have some feedback on this, I would be welcome to get it. So I'm going to focus today on clinical trials, but it's very hard to talk about clinical trials if you don't talk about standard treatments. And this, as everyone knows on this call, involves either surgery or radiation. And what I've highlighted here are some outcomes for surgery for vestibular schwannoma, because that's where we have the most information. For individuals who either have NF2 related schwannomatosis or a sporadic vestibular schwannoma. That is a person who does not have NF2 related schwannomatosis. And I've listed the outcomes here where you can see that hearing preservation, that is retaining hearing, is in about half of individuals with NF2 related schwannomatosis who have surgery, almost 70% if you don't have NF2 related schwannomatosis. And most importantly, that individuals who have NF2 related schwannomatosis are highly likely to get another tumor after surgery. Whereas this is very uncommon in people who don't have NF2 related schwannomatosis. And that is for all the reasons described by Professor Evans. That is, if a person is born with a NF2 genetic alteration in some or all of their cells, they're at risk for developing additional tumors. So unlike a person who doesn't have a genetic predisposition, that person without the genetic predisposition is not likely to develop a new tumor, but people with NF2-related schwannomatosis are. And I think that's a key concept in terms of thinking about surgery for these tumors. For radiation, we look at the combination of tumor control and hearing preservation. And if we look over time, we can see that tumor control in many series, about 84% of people are free from tumor growth. So that's good at 5 years, but you can see that number drops. And it's clearly inferior to individuals who have no genetic predisposition, and for the same reasons that I described above. One thing that's underappreciated is that while individuals who get people with NF2-related schwannomatosis get radiation for their tumor, you can preserve hearing at 1 year, but at 2 years and 3 years, that rate drops off. And so we do worry about hearing loss even with radiation treatments. And some key points to consider for standard treatment, I would argue that the decision to have surgery, it really has to be individualized. And that's a very complicated decision based on the hearing status of both ears and the tumor size. It's also important to remember that having surgery allows a surgeon to place a cochlear implant or a brainstem implant, and for many individuals, that's very important. Similarly, the decision to provide radiation is based on the hearing status of both ears, based on age, which I'll talk about in a second, as well as tumor size, all of which will be shown in the next slide. And of course, we'll be talking about chemotherapy in this setting. So just briefly, we could have a whole 20-minute talk on the risks of surgery and radiation, but I would argue that these risks are primarily neurological because these are focused directly on where the tumor is. So if we look at surgery, we can see that, or I believe that it's clear that the risk increases with the number of surgeries. That is, if you have one surgery, you're unlikely to have a complication, but if you have 10 surgeries, and many people unfortunately need 10 surgeries, you are likely, excuse me, you're likely to have a complication at that point. Okay. Also, if surgery is on one of the brain tumors, complications could include facial weakness, balance problems, a dry eye that comes from facial weakness, which can lead to reduced vision, voice weakness or hoarseness if the vocal folds are impaired, and swallowing difficulty. And of course, for spine tumors, we worry about weakness, which could be profound, even including paraplegia, as well as walking difficulty. For radiation, we believe that the risk increases with decreasing age. That is, a child who receives radiation is more likely to have a problem than an adult. And Dr. Evans has published really important work with his team showing that that risk is up to the risk of cancer, which is related to age, can be as high as 6% lifetime. But in addition to that risk of cancer, as I outlined, you can see hearing loss, facial weakness, and brain swelling, all which can happen after radiation treatments. And so in my mind, the way I think about it, and mind you, this is one person's opinion, I think about how likely a center is to recommend either observation, which means no treatment, watching with MRI scans, surgery, or radiation. And I've divided this for vestibular schwannoma into what I call early stage. There's two tiny little vestibular schwannomas here, mid stage where you have larger tumors, and then what I would call late stage where you can see this brainstem compression here. Often we'll watch individuals early on, so we're much more likely to observe early than we are later. And that's because a person who has surgery early on can lose hearing in that ear, and so often we'll try to avoid those complications. However, we do know that surgery really has two peaks. Early on, when the surgeon and the treatment team is focusing on hearing preservation, and later on, when tumor compression develops. It is rare, I think, to see surgery for these middle stage tumors unless there's a reason to get them out. And although radiation is not as common at my own institution, it is used widely. And so therefore, it's important to think which individuals are likely to receive radiation. And again, I would argue that it tends to be less often when the tumors are very small because they're typically asymptomatic. It also tends to be less common late stage because when tumors get too large, they become unsafe to radiate due to brain swelling. And so typically radiation, I find, is more for growing tumors in that middle stage. If we think about meningiomas and ependymoma, it's a little bit easier, but a very similar calculus. When tumors are small or medium or large, the likelihood of observation goes down as tumor grows. The likelihood of surgery goes up as tumor grows. And for the reasons I said before, I think radiation is most common when you have a middle-sized tumor that is growing somewhat rapidly. Again, this is my own view, and I'm sure other clinicians might have slightly different take on it. So why then talk about chemotherapy and other forms of systemic therapy? So the advantage, I think, of considering systemic therapy is that there's less risk of direct neurological injury to the tumor or to the brain or nerves or spine that are nearby. And also, we have this theoretical benefit of treating multiple tumors and tumor types all at the same time. What are the disadvantages of systemic therapy? We think about the risk of non-neurologic side effects, such as fatigue or nausea, rash, or laboratory abnormalities. One of the things we've determined is that even tumors that respond to treatment can grow when you stop it. And so oftentimes continuous treatment is required for many years. And we recognize and acknowledge that this is expensive and time consuming and is a tremendous burden for most of our patients and families. So making the case for systemic therapy, how does a clinician who does clinical trials think about the different types of systemic therapy? This is not the only way we can divide it. I think of the buckets of chemotherapy, immunotherapy, and genomic medicine. So for chemotherapy, that would be some kind of medicine that slows the growth of tumor cells, or if we're lucky, kills them. It works throughout the whole body, but it's not specific to tumor cells generally, meaning that there are off-target side effects. For immunotherapy, this is a newer type of systemic treatment. It's a treatment that activates or strengthens the immune system. And in doing so, it helps the body to recognize the tumor as abnormal. And because it's focused on the immune system, it's more targeted than chemotherapy, although it should be acknowledged that if you activate the immune system too much, you can get a lot of immune-mediated or immune-caused side effects, and that's important to recognize. And then finally, genomic medicine or gene-directed therapy. It has different names. These are medicines that target specific genetic changes in tumors, building on all the work presented by Professor Evans. These medicines can modify or replace genes and are designed to be highly, highly precise. So there's no way in a 20-minute talk to go through every clinical trial, past, present, and future. I want to highlight here what my research has pulled up, the completed trials for NF2-related schwannomatosis. On the left column are all the drugs. These have been registered for the most part at clinicaltrials.gov. You can see when these studies were initiated, what phase of study, how advanced they are between phase 0 and phase 3, the molecular targets, how many individuals were treated, how old these individuals were, and tumor endpoints, what they looked at. Did they look at vestibular schwannoma, meningioma, and the results? And I'll come in the next slide to what we're using, but you can see here that in general, there's been a one drug, one tumor approach. And that has contributed to some of the challenges of rapidly screening medicines. And I'll talk about that at the end of my talk. So I've selected from that long list of drug studies, drugs which I believe are in use today. And I want to highlight this is for selected patients. And it's, again, beyond the 20-minute talk to go over that. But everolimus, where the studies have shown no shrinkage, no hearing improvements, but some patients have had a delay in tumor growth. And so we use that in some people, particularly younger patients, to prevent tumor growth. Lapatinib, which showed tumor shrinkage in about 20% of tumors, hearing improvements in about 30% with a time to tumor growth of 14 months. Bevacizumab or Avastin, as Professor Evans mentioned, which can cause shrinkage, tumor shrinkage and hearing improvement in about 35 to 40% of individuals. And more recently, bergatinib, which was designed to study all different tumor types and shows tumor shrinkage in about 20 to 30% of tumors. So these are the current trials that I could uncover as of this morning for NF2-related schwannomatosis, and I'll go through them quickly. Selumetinib, which is approved in the United States for treatment of NF1, different condition-related plexiform neurofibromas, has been studied in NF2. That study is complete, and we're waiting to hear the results. REC-2282 is a drug that has been studied for meningiomas. That study has been terminated, suggesting that it has not shown benefit. Crizotinib, that study run by the Department of Defense NF Consortium, that is completed, and we're anxiously awaiting the published results of that study. Doxycycline, which is a widely used antibiotic, that study is active but no longer recruiting because they have reached their number. This involves injection of doxycycline directly into tumors. There is an ongoing study of aspirin for vestibular schwannoma, which is active but not recruiting. We're awaiting results of that. Neratinib has been studied and is currently an interim analysis. That work has been presented at the annual NF meeting, and we can refer back to those. There are 3 trials here, of which results I don't yet have. The first is a gene therapy out of China studying an agent called ST002. My understanding, according to the website, it's not yet recruiting individuals. There's also a MEK inhibitor called FCN159. That study is recruiting in China, according to the website. And then one more small molecule called Trinumin, which is out of a wonderful company in Korea that they now have phase 1 safety data for patients from Korea, and they are looking to open studies in the United States for phase 2. And my understanding is we don't yet have that trial up and running. So what trials are under development for NF2-related schwannomatosis? There's a common anti-high blood pressure medicine called losartan. The indication is to prevent hearing loss. It's being run through the DoD NF Clinical Trials Consortium. The protocol is complete, and we're just looking for funding to start that. There's the first combination study that looks at bevacizumab, which, as we talked about, is being widely used in the UK, United States, and other countries. We want to improve the effectiveness of bevacizumab by adding retifanlimab, which is an immunotherapy that will work with bevacizumab to stimulate the immune system. We hope the combination is more effective than bevacizumab alone. That protocol is complete. It gets reviewed by our IRB on Monday, so we're getting very close. And I'm sure I'll eat my words, because I often do, eat my shoe, but I'm hoping that we can launch this study in 3 to 6 months. Exciting compound called VT3989, which is a study made by a company called Vivace Therapeutics. It's under development in the Department of Defense NF Clinical Trials Consortium, and we hope that that'll move forward, but of course the company needs to approve it. There's also interest in a combination of defactinib and avutometinib, which are 2 medicines that are approved for ovarian cancer. Again, under development, but it would need approval by the company, excuse me. And then finally, a tumor vaccine that has been studied in Japan and shows interesting activity. And we're hoping that we can move that forward in the United States, although that will need some additional studies as well. So what's the future of clinical trials from my perspective? Again, this is a one-person perspective. I'll talk quickly about innovative trial designs, immunotherapy, and genomic medicine. So here are 2 innovative trial designs in NF2. On the left is the Intuit NF2 study, which is being run in the United States at 7 sites, including Mass General Hospital. It's what we call an adaptive platform basket trial. And I'll just quickly mention that it enrolls people who have growing vestibular schwannomas, growing non-vestibular schwannomas, for example, let's say in your arm or brachial plexus, growing ependymomas, growing meningiomas. The goal was to have every patient with a growing tumor eligible for a study. That's the basket portion. The platform portion it allows us to add drugs as we go along. So first we studied brigatinib, that's published. Then we studied neratinib, which is now an interim analysis. And as I told you, we hope that the retifanlimab bevacizumab arm will be open soon. And we're working on arms D and arms E. Losartan is innovative. I mentioned that this is a well-studied anti-blood pressure medicine. And what's innovative about this design, without going into details, is it's our first prevention trial, meaning instead of waiting till somebody gets symptomatic or has a tumor that requires surgery, we want to intervene sooner in younger people, and we're hoping to start at age 10, even before hearing loss is present. And we hope that we can now move chemotherapy trials up front to that earlier stage rather than late stage that I described before. In terms of immunotherapy, the potential is to avoid or minimize the need for chemotherapy and, of course, surgery and radiation. And we hope to, what I put in parentheses, use the immune system to reject established tumors, meaning to treat the bigger ones. And then for me, the holy grail would be, can you train the immune system to surveil or watch out for new tumors and prevent them when they're small before they become large enough to even show up on MRI scan? And then I'll just point out from my own perspective, we're so focused and committed to treating our younger patients, that is patients under 21 or under 18. It's such a challenge in terms of drug development because our regulatory agencies rightly don't want us to expose children to a lot of risk, but we know it's so important. And so I think immunotherapy, that is harnessing the immune system, is particularly attractive for our younger patients. And then the last two slides on the future of genomic medicine, I think it's clear from multiple publications and from fundraising through NF2 BioSolutions that gene therapy is here. Multiple preclinical studies support gene replacement. The main challenge is how to deliver the NF2 gene. And for example, questions that come up, how do we control which cells receive the gene? That has lots of implications for how we give it. And then how do you prevent too much of the NF2 gene from getting in each cell? These are theoretical questions that everyone is working on. And then finally, it is Rare Disease Month in the United States. And so I wanted to make sure everyone heard that on Monday, February 23rd, the FDA launched a framework for accelerating the development of individualized therapies for ultra-rare diseases. This is now out for comment. And what that means is we're trying to develop a framework where we can do this genomic medicine for a private genetic variant. Dr. Evans pointed out that there's a wide range of genetic variants that cause NF2, and sometimes we hope we can target ones that are just in a specific family that might be rare and difficult to study on a larger scale. So we look forward to this update to the FDA policy. And then finally, just a thank you to all the patients and families that have participated in clinical trials and supported these efforts. We know what a challenge it is to be involved in clinical research. And here's a friend who allowed me to use this photo. This says balance, and of course, just emphasizing not just the symptom, but the balance people need to live with this condition and how much resiliency our families really show. So we're very grateful for that. And with that, I will unshare and join Professor Evans in a question and answer session, I think.
Great. Thank you both very much. You presented lots of information. A lot of our pre-questions that were submitted with registration you addressed. So you really covered topics that people want to know about. Thank you. Some of these might repeat some of what you've already said, but I will hop into the questions. For Dr. Evans, can you please discuss mosaic NF2 and the potential recurrence rate in offspring? My local geneticist told us you have recently published research on this. Can you share the name of the paper?
Oh, gosh. Well, I've published quite a lot on mosaic NF2 over the years. So there are multiple papers that the risk depending upon the level of mosaicism. The most important thing is if you can't find the genetic fault in blood and it's only in tumor, the risk of transmission is extremely low, under 1%. We've actually never seen it and there've been over 150 children in those families. So it's very, very reassuring if the genetic fault is a spelling mistake that you can identify in two separate tumors that isn't present at any level in blood. Obviously, in men, you can test sperm if you want to look at the level, but it's present in blood. The percentage that you find it in blood is probably very close to the percentage risk of transmission. So if you find it in an allele frequency of 12%, then it's probably a 1 in 8 chance, a 12% chance of passing it on to the children. What this shows is if it's in blood, it's in your crest because you've got NF2, then it's probably also going to be in your gonads, and you will have probably around the same proportion of cells affected. It's not an exact science, but that's the main thing. I can send later on a bunch of my mosaic papers if you wish.
Thank you. Another question we have. My 12-year-old daughter has NF2 with a clinical meningioma that has grown over the past 8 months, but is not yet causing acute neurological symptoms. In this situation, how do you decide between continued observation or starting early systemic therapy such as brigatinib?
Well, I mean, it is looking at the rate of growth and whether the meningioma is a danger to other structures. So, you know, meningiomas often grow very, very slowly, and sometimes they stop altogether. So going into the treatment might have been unnecessary. It may be over-treatment. So we are careful not to just dive in and do something because there's a tumor there. So if it starts to grow rapidly, then I think your hand is forced because it's probably not going to stop growing. But if it's a slow grower, there are certainly meningiomas that switch off and stop growing. And we have followed many NF2 patients with meningiomas that just have stopped growing, but they can occasionally restart again. But it's a balance. It's a discussion with all of the specialists, the neuro-oncologist, the neurosurgeon, you know, the symptoms through the neurologist, and deciding, you know, is this the time to do something? And obviously brigatinib is a choice now, but it's not a magic bullet. It doesn't work for every meningioma, and if they're very easy to remove and that you haven't got a lot of meningiomas, then surgery might be the best option rather than a systemic therapy.
And the only thing I would add is, well, I agree with everything that Gareth said. The only thing I would add is just it also depends on how many other tumors a person has.
Yeah,
because
I'm sort of intimating that. Yeah.
Yeah, because just to flesh it out, just to make sure we're clear, in somebody who has multiple growing tumors, the risk benefit is more towards the benefit side, whereas if it's an isolated single meningioma, maybe less so. And so I think it really highlights what we were saying earlier about individualizing it. And so it's hard to come up with just absolute suggestions as much as it depends on the growth rate, the age, any surgeries before, the location, other tumors, and so forth.
And that's the great thing about systemic therapy is you can treat multiple tumors at the same time. Whereas surgery, you can't just remove 20 tumors in one go. It's just not possible.
Okay, another question. If an international pediatric patient were eligible for a brigatinib trial, what would the monitoring schedule look like during the first few months? Is any follow-up possible outside of the US?
So it's a complicated question for me in the sense when somebody uses the word trial, what that means to me as a clinical trialist is that there's something called a protocol document, which is a document that's approved by the FDA on how every patient must be treated and managed. And so it doesn't matter what I could say right now because it would only matter what was in that clinical trial because these things are often very explicitly mandated. That is how frequent laboratory studies are done and whether they can be done locally or not locally. And so it's a little bit hard to answer that question. I think there's a lot of guidance in many groups. They'll monitor once a month early on. We know that a person treated with brigatinib, the vast majority get an elevation in a blood test called CPK. And so it's important to follow that at least early on to make sure nobody's having side effects. Usually it's easily managed without any dose modification. And so the labs are important, but it's hard to be definitive about the frequency and location, in a different clinical trial.
Thank you. We have a question from patient associations. We often find that our general practitioners do not have extensive knowledge of this disease. Would you approve the creation of a short guide on the management of NF2 endorsed by you, renowned doctors, with some useful information for both doctors and patients?
There are many publications like that. I wonder, Gareth, in the UK, if you have a document already available. I think the Children's Tumor Foundation does have some general patient-oriented recommendations as well. And I know on the medical side, the ERN and many other groups have gone through, of course, Professor Evans has written most of these on guidance, right? So they're definitely out there. I guess the question is, how do you get a GP to read it? Mostly in the United States, not so much in the UK, because they have done what Gareth mentioned. They've centralized their care, which is amazing. I wish we could all do that. But in places like the United States, a little bit more challenging. What do you think,
Yeah,
Gareth?
in the UK, we have the Nerve Tumors UK, who we do have guidelines for management, which are available through Nerve Tumors UK. We did publish a consensus guideline for management 20 years ago, but it does need updating. And the ERN, the Geneticist, which is in Europe, is planning to do an NF2 management guideline, and I think CTFR as well, potentially. Is that right, Scott?
Yep, I think we're working on all that. Yep. It's a great point, though.
Okay, another question. What is NF2's relationship to inflammation and the autoimmune system?
I think that's a lot of the work out of your group, Gareth.
So what we know is that these are immunogenic tumors, that you get a big infiltrate, particularly macrophages, which are blood cells that are involved in inflammation, and they're inflammatory tumors. And the tumors, so something about having an NF2 inactivation in these tumors, because the sporadic tumors also show it as well, is that it triggers this inflammatory response. And that's why we're trying drug Plotkin to see if, anti-inflammatory drugs will work in reducing the growth. And we know that the tumors that grow most rapidly, it's not necessarily the tumor cells that are causing that growth. They're filling up with inflammatory cells. And the inflammatory cells, when you do the pathology, can be 70-80% of the tumor. And that creates a problem when you do genetic analysis, because actually those tumor cells, if they're mosaic, won't have the genetic fault. And it means it's harder to identify the genetic fault because of that. But yes, we don't know the exact mechanism yet, but loss of NF2 and formation does seem to, in most individuals, have some sort of an inflammatory response. And the worse the inflammatory response, the more rapidly those tumors grow. So finding a way of treating that is obviously a very important thing to do.
Very good. Well, we are at time here. Do either of you have any closing comments?
No, just a pleasure to chat to everyone.
Yes,
Agreed.
we are deeply grateful as a parent. Thank you so much for sharing generously your time and knowledge. Thank you to our audience for joining us today and submitting all these great questions. Everybody have a great day.
Thank you.
Thank you very much.
Cheers.